Hi everybody, happy Saturday. Today's show is all about menopause, hormone replacement therapy, and women's health. And I have a special guest, Dr. Kristina Sogocio. So I'm going to let you guys start coming on. Let me tell you a little bit about her. Hi everybody, happy Saturday. We're talking menopause, hormone replacement therapy, women's health with a very special guest, Dr. Kristina Sogocio. And so I'm going to invite her on now. Let's see if I can get her on here. Let's see. At KS. Hold on, guys. There we go. We have an information-packed show, you guys. So many things to talk about when it comes to women's health, but particularly for, oh, hello.
Oh.
Hello. Hi, Dr. Sogocio. Let me see if I can get this light to go back on. Something is going off. Hold on 1 second. Okay, introduce yourself a little bit while I work on this plug. I was telling everybody we're talking all things women's health, but particularly menopause, perimenopause, hormone replacement therapy. Everybody, this is Dr. Kristina Sogocio. She is from my hometown of Merced. Tell us a little bit about you while I crawl behind the couch and try to plug this thing back in, okay? Go for it.
Hi, everyone. I'm Dr. Tina Sogocio. I am from Merced, California, and I am an OBGYN. I have been in private practice for the last 17 years. 15 years of those have been in Merced, and I'm not originally from California. I'm from the Midwest, but my husband is from California, and that's how we ended up in Merced. And I have been very, very blessed with a thriving solo practice for the last 15 years in Merced. So,
and for those of you who don't know, I grew up in this little town of Merced, California, on a small farm. And so when I heard about, it's so difficult to find a good hormone replacement therapist. And so when I found out that there was somebody doing good work in Merced, and a bunch of my high school friends said, you have to talk to Dr. Sogocio. I'm like, yes, let's get you on. So tell me how you transitioned a little bit from being a typical OBGYN, delivering babies, doing pap smears, telling people when to get a mammogram, to this now focus on women's health, perimenopause, menopause, hormone replacement therapy. How did that shift for you?
That's a great question because, a lot of OBGYNs will, say, yeah, we have experience with, midlife women with menopause. But to be quite honest, a lot of us general OBGYNs don't get a lot of specialized training in our residencies, for midlife women. So I found myself in my practice aging with my patients. As I said, I've been in practice for 15 years.
So how old are you, Dr. Sogocio?
54.
Yay!
Proud. And, as I've aged with my own patient population, of course, I was going through my own transition of perimenopause through menopause. And I found that their conversations with me and my ability to connect with them much more really started to sit with me very differently. And I realized that because I had not had that specialized training way back when, I needed to go back and re-educate myself and get caught up with the new emerging evidence, the data, and really reprioritize the conversations I was having with my, because they were all asking me different questions at this point. And I found myself having these conversations a lot more easily because I was going through the very same things.
Right. So you re-educated yourself and you aged right along with your patient. I love that. I love that. Okay, so at what age about was that? Because I want to kind of do a little bit of a pivot here that will kind of tie into like when you kind of did that pivot yourself and started really re-educating yourself. At what age should women really be paying attention to their hormonal health and the effects of your fluctuating hormones on your health?
Well, I think that's a great question. I always say the sooner the better. And I've always been a big proponent of having even my younger patient population, even my, my teenagers, really start paying attention to their bodies sooner.
Right.
And know their anatomy, getting to know the details of their menstrual cycles, really paying attention to all of those things that happen. And then I find that if we can encourage women to pay attention early,
Yeah.
the perimenopause and menopause, along with education, don't come so abruptly. And the feeling like, oh my gosh, where did this all come from? What's happening to me? Am I going crazy?
Right.
Getting sicker? What's going on? I think the sooner that we're in tune with our bodies, the easier it is to enter that transition and then start our own perimenopausal journey.
I love that. I love that the earlier the better. And I tell my one-on-one coaching clients that all the time, like the earlier the better, because to establish a baseline of what do your hormones look like earlier in life, in your 30s.
Right.
Because correct me if I'm wrong, but perimenopause can begin in your 30s.
Yes, absolutely. Because if you look at the age range, the average age range for menopause, it's 45 to 55. And what we understand about perimenopause is it can start as far back as 7 to 10 years prior to that menopause.
30s.
Absolutely. So if you have someone who's 40, who's truly menopausal with the changes in the blood work, the symptoms, imagine that perimenopause is starting even in the early 30s, maybe even in the late 20s. So we have to be very cautious about assuming that menopause starts later on, really later on in life when we're older.
And perimenopause is not, you can have the symptoms of the hot flashes, and we're going to get into these, and I want to pick these apart, but the symptoms of the hot flashes and night sweats and brain fog and all of that stuff, when I get a one-on-one client and they start saying, I don't know why my skin is so dry, I'm not menopausal, I'm only 40, and I'm like, you are. This is part of it. So I want to get into, I think it's so smart for people to start young and really start paying attention to their body.
Yes.
But let's start talking about what are these symptoms that people are supposed to be paying attention to. And so let's just start with the menstrual cycle itself and what changes happen that will indicate that you're in estrogen decline, you're in hormonal decline.
Correct. Perimenopause is really that I always say the ovaries send the memo that we're going to be retiring, but we're just not going to tell you when. That's the analogy that I give with the start of perimenopause. And the symptoms that really start to manifest can be as simple as our menstrual cycles. So we might see ourselves bleeding heavier. We might have more cramping pain. We might find that our cycles are coming earlier or later, or we might be bleeding more than once in a given month, or we might see ourselves or see our cycles spacing out. And so, or all of the above. So it's very telling when women start to talk to their providers about their menstrual cycle changes, because those can be the very first changes that absolutely.
Chaos to Clarity with Marcy just commented. She said, my PMS was for 2 weeks and I thought my world was falling apart. And to have PMS for 2 weeks, I mean, oh my God, I can't even imagine. I would imagine that your world would seem like it's falling apart. But that is a big indication that you need to get in and see a hormone specialist. Okay.
Know that those fluctuations can be very profound, and so when they're up, we feel maybe a little too much, and when they drop, we feel really we feel like we're really down in the dumps. So yes, the 2 week PMS, those symptoms can certainly be a lot worse as we start going through that transition.
So it could be irregular periods that you start looking for, a heavy, very, very heavy slow. You can skip periods or even spotting. And all of this is an indication. Get into the doctor and see your, okay. So the typical thing that we see, like people don't think that they're in perimenopause or hormonal decline unless they're having the typical hot flashes. And I was one of those people, because that's when I had interviewed several hormone replacement therapy doctors, Dr. Nina, MD in Beverly Hills, which is my personal hormone specialist. But I had interviewed her and talked about like hormonal decline and the age and hormone replacement therapy and all of that while I wasn't on it yet. And that's when we're like, okay, let's start testing the hormones. And the hormones came back, and yeah, I was in decline, but I felt fine. I didn't have anything until one day I did. And it was like the inferno that was coming from my chest was like nothing I'd ever felt before. And so that is a big, you know, slap in the face of, okay, girl, get in to the doctor.
Yes.
But let's talk about other things as well, which is you can have not only those big hot flashes, which can last up to 5 minutes. And I once had a hot flash that literally lasted a half hour.
Yeah.
And I was so miserable. I got in a cold shower. I then got in a cold bath. It still did not alleviate that hot flash. It just had to.
Yes. So hot flashes are quite variable between women. And like you said, they can last a long time. They can be very, very short-lived. They can be extremely intense, or they could just be little blips where you just feel a little hot. Some women, or some of my own patients will have said, you know, I just felt like the heat was rising from my chest up to my head, and then it went right back down, you know, or it's just a little sweat on the brow.
Yeah.
So lots of different ways that hot flashes and night sweats as well can manifest.
Yeah.
But the thing about the vasomotor symptoms of how we refer to those things is that while there is a very high percentage of patients that do experience hot flashes and night sweats, it might not be the one symptom that manifests first, and so women tend to think, well, if I don't have any or any hot flashes, I'm not in menopause, or I didn't go through menopause. And I'm like, oh, no, there's
you can't avoid it. Whether you have symptoms or not, your hormones will still decline. You're lucky if you don't have symptoms, and we're going to get into the benefits of being on hormone. Even if you don't have any symptoms, the benefits of being on that. But I had a question here from Mama Karen 10, who says, thank you for doing the show. I have a question. I'm almost 56 and I'm just now going through menopause. You probably are not just now going through menopause. As we've learned, it's been happening for a long time, but really only experiencing very mild symptoms. I had an ablation 10 years ago.
Yep.
So does that decrease the symptoms?
No, because an ablation, which is a fantastic intervention for bleeding issues, especially heavy bleeding, ablations pretty much wipe out the lining of the uterus so that we do not generate enough tissue to bleed every month. And so for those women who have had successful ablations, they don't have the menstrual changes with bleeding necessarily to really give them an idea if they're starting to go through perimenopause or even through menopause, because if their ablation is very successful, they'll stop bleeding altogether. And so, you know, we have to then take that into context when we do our interviews and our medical histories with our patients, because if they haven't had a period, look at the other things that are going on.
Look at the other things. And so we're going to get into that too. Night sweats, which I was having. That's why I have a cooling mattress pad on my bed, because it helps me to kind of stay cool. But now I'm on hormone replacement therapy and those symptoms have gone away. But during that time when I was getting on hormones, that cooling mattress pad totally saved me. What about like joint pain? How is that related?
Yes. Well, you know, it's interesting because just going back about the hot flashes, I myself never had any hot flashes or night sweats. My two main symptoms were joint pain and brain fog. And so, surgeon, when I started experiencing arthritis in my hands, and there was a lot of difficulty with being able to get through my surgeries, I started to really panic. And, you know, joint pain is a very, very common symptom, but it's often misdiagnosed in midlife women. And they
Totally.
go,
We think it's just arthritis, right? Oh, we just have arthritis,
or
normal part of aging.
or you know, if someone is an athlete or has done a lot of physical activity where repetitive things, and they'll, you know, the feedback might be, well, you know, you put your body through wear and tear, it's probably likely you're going to have that arthritis at this point, when in fact that's not the case. Especially once you've ruled out other possibilities, the majority of women in midlife over the age of, you know, 35, 40 are going to likely get misdiagnosed, but a lot of that is perimenopause, menopause, because the density of the estrogen receptors are quite high in our joint cavities
Oh,
and our
that
bones. Yeah.
is just a light bulb moment for me. And I hope you guys are having some of these light bulb moments as well. The estrogen receptors in our joints,
Yes.
are high.
Yes.
So that when we are in estrogen decline, it makes sense that we're going to get pains in our shoulders, pains in our hands, pains in our knees more.
Yep.
That could be misdiagnosed as just arthritis or a normal part of aging, when actually it's an indicator that we're in hormonal decline.
Right, because part of the whole perimenopausal menopausal transition, it's an inflammatory transition. And so all of that inflammation will start to affect almost every organ system, and very notably in our joints and our muscles. And so, yes, absolutely. It's the fluctuations of our estrogen and of all of our hormones, really. But once we hit menopause, where we've stopped having those periods for a full year, that progression of arthritic pain, full body pain, bony pain, any kind of body pain starts to become very obvious. Yes.
Wow. Okay, which brings us to another thing, which is the mood changes that happen with menopause. Because if you've ever noticed, you guys, a lot of us midlife women, there's anxiety that sometimes increases. We sometimes think, oh, this is because my kid's gone off to school, or you know, my kid is now like becoming a young adult, or we can blame it on a lot of different stuff. I'm depressed because I'm an empty nester. But yet anxiety and depression are symptoms,
yes,
of estrogen deficiency.
Yes. And it's, and talk about the most misdiagnosed of all symptoms of perimenopause. Anxiety, depression is probably the top one, because if a woman goes to her provider and says, hey, I have hot flashes and night sweats, that's typically a no-brainer for the provider. But when we have midlife women who are starting to complain about anxiety, depression, or depressed thoughts, or just, you know, that brain fog, the difficulty concentrating, all of the neurocognitive, yes, it is the fluctuations of our hormones during perimenopause, that insidious decline during perimenopause. And as we get closer to that menopausal transition, it's the mental health changes are profound. And, you know, yes, for those of you of patients who have been thrown an antidepressant right off the bat, yeah, that has been the probably number one miss, you know, us as providers.
Yeah.
We
and that's part of why I decided with this particular interview. I normally, when I do these interviews with, and I've had other hormone specialists on, I just go through the symptoms, you know, menstrual cycle changes, hot flashes, night sweats, joint pain, mood changes, ADHD symptoms, right? We go through them so quickly. And I think that if we sat in those symptoms for a bit, knowing that every body is different, everybody's transition to menopause is going to look a little differently. You might get, you know, arthritic symptoms in your hands, or you might go and seek counseling because you're all of a sudden in a state of depression.
Right.
But to really understand before you just throw medication at it, you know, throw, you know, Aleve at, you know, to try to get rid of the pain, or throw, you know, Prozac at something because all of a sudden you've got anxiety or depression, you're not treating the root of the problem.
Correct.
And so to highlight these as, and I think it was Mama Karen 10 that said like her symptoms were very, very mild. think about all of the symptoms that we just talked about. Do you have an inability to go to sleep or to stay asleep? Right. Do you have joint pain that is new? You know, are you experiencing anxiety or depression? Yes. One of the symptoms that I kind of helped one of my clients with the other day was she didn't have hot flashes and she was sleeping okay, but she'd always just slept okay. But what she was finding is that she could not stay on task.
Correct.
And she got up to a level in her job where she had been like one of those super warrior women. And there's a ton out there that raise kids, work, take care of everything, like just carry the weight of the world on their shoulders. And she got to a point where her kids were now away at school, and it should be a time when she can scale that ladder, and she could not stay focused long enough to get something done before there goes the next thing. I need to work on that. And it was an inability, almost like ADHD symptoms.
Yes.
An inability to stay on task. That's very much tied to hormonal decline.
Correct. And one of the important things to remember about the mental health changes and the neurocognitive changes is that they'll stack on top of each other. So the more that we feel that we don't have control over what we're saying in a conversation, or how we're leading a board meeting, or someone like me who's in a surgery, you start to tell yourself stories like, oh my gosh, what's happening to me? And then you start to get very insulated with your thoughts. And then that's where the roller coaster for a lot of women starts to really get worse, is because we don't have enough support to tell us otherwise. And we're feeding, more and more of this doubt, right? Like, oh my gosh, what's happening? I'm going crazy. Or maybe I am just getting, sicker and I can't do this anymore. And then we get more anxious and we get more depressed and we can't sleep at night because we have all these worries. It is a profound, the mental health and neurocognitive changes are so profound. But what I have found with most of my patients, Darnell, is that it just builds on each other, and it gets for them. And that's where we have to be very careful as physicians, as providers, is that we need to make sure that we are diagnosing them properly.
That is exactly my point, why I really wanted to drive this home. And I know that there's a lot of questions coming up with people, and we're going to try to get to those. But what you just said, Dr. Sogocio, was so important, in that things compound. And what I do as a health coach is I try to shine a light on the fact that everything is so connected. How you sleep is connected with your food choices that you ingest that day, right? Your stress levels are so connected with how you sleep. All of these things are so connected. When we're in estrogen decline, and there's a lot of other hormones that decline as well, and we start putting on that midsection gets bigger. How do you think, you guys, that affects your self-esteem and your depression and your anxiety and your ability and your desire to work out? It's success begets success, so that when you are optimally, your hormones are working optimally, and you don't have all of those symptoms, you're more likely to watch what you put in your body. You're more likely to think positively about the future and what a midlife woman can do. It's all connected.
Absolutely. It's, for me, it's a no-brainer, right? When we feel better, we do better. And for 17 years as an OBGYN, I've seen that in my own patient population. When they feel better, they do better. And that is the reason why I started really diving in more with midlife women's healthcare, because it was the forgotten age population.
Yeah.
Almost like, well, you have a baby, good luck with that. And yet we have these next 30, 40 years on average, because we're all living longer now, that we really have to take care of our women, our midlife women, better because of all of these things. And you're right, it compounds one after another. And then we just need to be able to support our women better. We need to educate them. Going back to the question you asked me, we need to be paying attention sooner.
Yeah.
And educating our women much sooner, so that none of this feels like it's like someone knocking you over the head, like nobody told me.
Exactly. And for people that wait until they're in their mid-50s, just like to be educated and to like really pay attention to those symptoms that probably started 10 years prior.
Possibly, yeah.
The little things, you know? So now we're talking about how it can compound and affect things. Now let's talk about vaginal dryness and lack of sexual desire, because
Woo, that's a whole nother hour, my friend. So,
well, that is like a lot of people just think like, oh, this is a normal thing. You know, I've been with my husband for a long time. No, if your hormones are in decline.
Yes,
this is an indication.
Absolutely. The genital health is so important. You know, I can talk about everything south for, you know, for days to come here, but the most of
another live show where we talk about everything south.
Yes. Well, the most important thing is to understand that the genital tissue, the tissue outside of our vagina and inside our vagina, all of that is affected by the changes of our hormones, and is certainly the decline of our hormones. And so there can be no hot flashes, no other systemic problems or symptoms of menopause, but it could just be urinary incontinence.
Yes.
Vaginal dryness, it could be irritation, pain with intercourse, even decreased libido, you know, or recurrent bladder infections. You know, these are the things that make up that genitourinary syndrome of menopause, and often those get misdiagnosed or treated as well.
Absolutely.
When a lot of that are the changes of the loss of hormones that are leading to atrophy, loss of lubrication, loss of sensation, loss of blood flow, a tightening of the tissue that feels uncomfortable. So yes, genital health is so important to address.
Yeah, that also, if you guys, you know, when you're in a mode where you're having great sex, you know how that affects your depression and your anxiety, right? It's all super connected. And I want to get back to this one little point, and then we'll move on, because if you did not think that hormone replacement therapy was something that was going to benefit you, think about vaginal atrophy.
Yes.
What that means is the shrinkage and the loss of your vaginal tissue. It will deflate like a balloon and start hurting you.
Actually, and also to add to that, and we can't forget that our pelvic floor is also made up of 14 muscles, you know, down there that help support our bladder, our uterus, our rectal area. And so, you know, the tone of our pelvic floor muscles, it changes with perimenopause and menopause as well. Yeah. So women can feel loose. They can feel like maybe something's dropping or something's coming out, or they don't have the same sensation during intercourse. And all of that can be a combination of the pelvic floor muscles as well as the tissue, the vaginal tissue inside. Yeah. So those are very important components to also remember when it comes to genital health. Yeah.
Yeah. And when we get into which we're going to get into in a second, I've got a few more symptoms I want to make sure that everybody hears in case these are the only symptoms that you have, because like we have discovered, every menopause is going to be different. Every body is different. Somebody might not have hot flashes, but they might have, for example, incontinence. That's what you just talked about, that feeling of dropping, but that stress incontinence where you sneeze or you cough and all of a sudden you dribble, or you know, that urge incontinence when you're trying to put a key in the door and all of a sudden you're doing the pee-pee dance.
Yes.
Right? Both of these are indications of hormonal decline.
It can be. And
it can be.
Yes. You know, it's so important to have a thorough examination, because there can be some anatomical changes. You know, if anyone who's been pregnant or has delivered babies, especially vaginal deliveries, you know, the changes of the tissue and the muscles are automatic with that. And those will us over time, but those changes can certainly be exacerbated when it comes to perimenopause and menopause because of the loss of hormones also over time. But you know, once ruled out other things that can contribute to the stress incontinence and the overactive bladder, that urge incontinence, very much so, it can be just hormonal decline.
Yeah, and if you know that like I've grown 3 human beings in this body to full term. And so after I gave birth, you know, you've got that little bit of incontinence, but all those muscles came back and were fine. I didn't have any sort of stress incontinence when I sneezed or laughed or anything until I hit menopause. And then it's like, is this possibly a symptom of
Yes.
my hormones?
And that's a good point, because someone like myself who's had 2 pregnancies, but I had my babies by C-section, one would assume, oh, well, your pelvic floor never had to really go through, pushing a baby out. But I also didn't experience incontinence and urge and dryness until I started going through my own changes. So yes, those are just some of the important things to really tease out. With a good examination and a good history, because it can be all of the above.
Okay, so other things include skin changes. So when your skin becomes itchy and dry, how is that related to the amount of estrogen that we have in our body? Because estrogen is creates moisture in our skin, correct?
Well, one of the things that probably will, hopefully a good takeaway message from this talk here, is that our estrogen receptors are everywhere. They are on every organ of the body, and most notably the skin, which is the largest organ in the body. And when women start to have dryness, or they start to experience new onset skin changes like spots, that might not necessarily be related to exposures. If they're starting to notice, some droopiness, all of that is connected to our estrogen receptors. And so, yes, the common manifestations for skin are often dryness, but also just all of those other, subtle changes.
Yeah. Also weight gain, right? When we hit menopause, there's that menopause.
Yeah.
That menopause, midriff all of a sudden just starts extending. So how is that related to hormonal decline?
So what we understand about this is that the visceral fat, which is the fat in between our organs, which is a metabolically more active fat than our subcutaneous fat, the kind of fat that we pinch on ourselves. We know that with the decline of hormones, especially estrogen, the location of that visceral fat starts to change. It goes down to our midsection, or we start to see it a little bit around our bra area, our upper arm area, or our bra area. But yes, we understand that the hormonal decline, the hormonal changes will affect how that visceral fat is maintained and how it starts to shift. Now, the more important thing to remember is the majority of women will experience that shift down to their midsection, and their abdominal girth starts to increase. But what we understand is that with an increase in abdominal girth, we have an increased risk for cardiovascular disease, type 2 diabetes, and metabolic dysfunction.
And that's the next thing that I was going to talk about. Although I do want to talk about just 2 more symptoms: thinning hair.
Oh yes, or hair falling out. Yeah.
Hair falling out is a sign of that. You're like, immediately when I work with a client has thinning hair and they're coming to me for thinning hair, I immediately say, when was the last time you had your hormones checked? Let's make sure. How old are you? Are you on HRT? Like all of that stuff. So thinning hair is one, and also loss of breast fullness. So just your boobs shrinking and kind of sagging.
Yes. Well, almost everything shifts south. So breast. So yes, well, the integrity of our skin, that collagen production, is affected a lot by our hormonal decline. So yes, so where we see collagen loss, where we see lean muscle mass loss, yes, you're going to see it in all too.
So let's get into, then we've now talked about all of these symptoms. So everybody that's out there listening, if you are not the typical person that gets hot flashes or night sweats or an inability to stay asleep, but you are experiencing any of these other symptoms, I'm just going to breeze by them real quick. The hot flashes, the night sweats, the joint pain, mood changes, anxiety and depression, mood swings, ADHD symptoms, inability to stay on task, brain fog, so lack of mental sharpness, vaginal dryness, painful intercourse, changes in sexual desire, incontinence, sleep problems, difficulty falling asleep or staying asleep, skin changes, could be dry and itchy, increase in headaches and migraines, weight gain, particularly around the midsection, or a slowing of metabolism, thinning hair, and loss of breath. Wow, it's just menopause, the gift that keeps on giving, doesn't it? It's just like,
Yes,
here's all the stuff.
and there's I think what we've come up with is about 40 to 50 different symptoms of perimenopause, menopause, because we have to remember estrogen receptors, testosterone, progesterone receptors are all over the body. And so it really is a multi-organ shift.
Yeah.
And how it's manifested is going to be different for each person. Absolutely.
Yeah. And how we talked about earlier, how different health is connected. Your sleep is connected with what you eat and your stress and all of that. Menopause seems to be connected with literally everything.
Yes.
Literally everything. Okay. So who is a candidate? Well, yes, I want to talk about who is a candidate for hormone replacement therapy, but also in addition to estrogen, what are the other hormones that decline? Because we have more testosterone than we have estrogen. So what are the other hormones that also need to be assessed during menopause and perimenopause?
So we have to remember the three main ovarian hormones are estradiol, progesterone, and testosterone. And so, the majority of people just think about estrogen, progesterone, but we often fail to remember that testosterone is a very, very important sex hormone for women. And our abundance of its production is much higher when we're younger, but it is probably one of the hormones that, as it declines through perimenopause and menopause, the symptoms related to a testosterone decline are actually very profound. And so what I do is that we just genderized testosterone to be a male hormone, when in fact it is very much a female hormone as well. Yeah. So, women have tried to talk to their physicians, about possible testosterone decline or just having their testosterone looked at. They'll get shut down very quickly because the idea that it's not supposed to be part of a woman, but in fact it is very much a part of us.
Very much. In fact, we have more testosterone than we have estrogen. And I want to tell you just a quick story because we've got a lot of stuff to get to, but my sister, and being my sister, she's learned to advocate for her own hormonal health because I'm preaching about it all the time. But she talked to her OBGYN and she is on estrogen. And when she requested to get on testosterone, her male OBGYN said, literally chuckled at her and said, "What are you trying to do? Like grow big muscles and shave your face?"
Yeah.
And resisted giving it to her.
Yeah. Well, that's partly because there's just a lack of knowledge on the part of the physician, the provider, that doesn't understand the physiology of the ovarian hormones or the anatomy and the physiology of the whole pelvic area for women. So yes, it's unfortunate, and that is something we as women have to really educate ourselves on, as well as really advocate for ourselves. Because if, in my opinion, in my professional opinion, menopausal hormone care includes all three of those things. And the fourth is usually what I will refer as the vaginal hormones. So, full hormone care, estradiol, micronized progesterone, testosterone, and vaginal hormones. That's the whole.
I'm going to show you mine real quick. And I purposely did not take mine this morning. This is my progesterone that I take sublingually. I just take 5 drops of this under my tongue in the evening. And my estradiol, which I do 4 drops under my tongue in the morning and 4 drops in the evening. And then I have my testosterone cream, which I do 2 clicks and rub it into the inside of my arm. I just want to show people who have never been on it, like how easy it actually is to be on hormone replacement therapy. So I do 2 clicks of that in the morning, that's testosterone, and 2 clicks midday. And then I have DHEA.
Perfect.
And so you can tell me, it's the only one you didn't mention. Isn't this like a progesterone precursor?
It's actually a precursor for all of them, mostly testosterone and estrogen. So DHEA is a great alternative for those who might not necessarily tolerate straight up estradiol, progesterone, or testosterone. So that is another alternative, because there's a conversion of DHEA to estradiol or testosterone, and that can be another way for women to get some replacement. So DHEA is a very, very good hormone as a backup. DHEA is also it's also available in vaginal preparation. So some women will actually use DHEA in place of estradiol or testosterone vaginally as well.
That's a really great point. I want to get to that, because this that I just showed everybody, this works systemically in my body, so that all of those age-related diseases, Alzheimer's, dementia, osteoporosis, osteopenia, cardiovascular health, all of this is helping through all of those receptors that I have throughout my entire body. But do you also recommend an estradiol vaginal cream to be applied topically on our labia or inserted inside?
1,000%. Absolutely.
Yay! Okay, I'm doing that too. But that does not, for those of you guys listening, that does not take the place of this.
Right.
That's only for the vaginal health, correct?
So yes, so the transdermal preparations like the patch, the creams, injections, the oral preparations like you showed, the drops, tablets, there are those that actually tolerate pellets also. All of those are more systemic, and so they are going to take care of the majority of the body. Vaginal hormones are needed by many because of that vaginal atrophy and all those changes we talked about earlier, but they act very locally to the tissue, to the pelvic floor, and are not absorbed to a degree systemically that's going to make any difference. Right. And so very important to remember, because systemically, we're taking those hormones for not only symptom relief, but we're also taking it as an investment for protection and prevention for our future. Like you mentioned, the brain, the bones, and the heart. So we have to be careful about understanding why we're taking hormones and where
and what it does,
right?
What it does, because if you're only doing a vaginal suppository with estradiol, or you're doing a vaginal cream, that is not protecting you from all of those age-related diseases that we talked about. It's also not protecting the mood swings or the ADHD or the inability to stay asleep, all the hot flashes, night sweats. You put something up you just vaginally, it's helping with your vagina, but it's not helping with all of the other receptors that we have. Okay, so here we go. Who is a good candidate? There's a couple questions I want to reach before, and we have got like 20 minutes. Who is a good candidate for hormone replacement therapy, and who is not? Let's just address that real quick, and why a lot of people think that they shouldn't be on HRT.
So I am a firm believer that almost everybody is a candidate for hormone replacement therapy. Actually, I'll qualify my statement. Everyone's a candidate for hormone replacement therapy, because at the end of the day, it's still her choice. Now, there may be concerns, family history, personal medical history, concerns about cancers, all, different cultural, religious, ethnic, all these things go into our decision-making process about medications. But in hormone replacement therapy, everyone's a candidate for it if you want it, but that doesn't necessarily mean everyone tolerates it the same way, or doesn't require much more attention, because the adjustments need to be made more often. I think that's just so important, that it's such an individualized approach, decision, but in my opinion, everyone's a candidate. But of course, I go through all the risks and benefits with my patients. Ultimately, it's her choice. So
yeah, and just to kind of clarify with a lot of what I think is going on with the doctors who are not prescribing this. Number one, they're not educated when they're going to medical school about women's health and about menopause. But also, there was a really I wouldn't even say it was a study. It wasn't a scientific study because they found so many loopholes in it. But there was a study in which they did a long time ago with synthetic hormones with an over, like a 65 plus over
Correct.
population of women. And they found that it increased breast cancer. And before they even really picked that study apart, it was blasted on every news station that nobody should be on hormone replacement therapy. When that study was debunked, which it was, they did not do this. They did not do
No.
women the justice
Nope.
of shouting it from every news channel to say, wait a second, that's not true.
Right.
Hormone replacement therapy will actually help you live longer and better. And here's why. They didn't do that. And
Nope.
so all these doctors were left with, oh my gosh, we can't touch women.
Yep.
We can't put this back in them, even though this has been coursing through our veins since we were born, particularly since we had our first menstrual cycle. This stuff has been in our veins, yet all of a sudden it's dangerous to us.
Right.
It's dangerous to not have it anymore.
Correct. I mean, the data and the emerging evidence, and you're correct, the debunking of the WHI study, the results of those studies, for those of us who care, yes, we have all of this reassurances that hormone replacement therapy is safe. And we know the protective and preventative benefits that it's going to give us for the next 30, 40 years so that our quality of life is fantastic. But, there's a lost generation of women. That study came out in 2001. And the years that followed, women suffered tremendously. And it has been unfortunate that it has been an uphill battle for us to get medical and health establishment to accept that those original recommendations were incorrect.
Yeah.
I think partly because we just got used to saying, hey, good luck with that. Go age on your own. And the priority for women's health, midlife women's health, just plummeted.
It really did. There was like 25 years there where it was like, or 23 years where it's like all of those women that were aging during that time were just left with nothing. And those, when I first had a conversation with you, you said those are the majority of the women in the nursing homes today.
Yeah, I think majority of us can think about our mothers or our grandmothers or our aunts or family members or friends of the family. Like, there are examples of women in our that all of us have that probably suffered needlessly in the last 20, 25 years because of the damage of the WHI.
Gosh,
but
talk about a disservice to women. That is so maddening. That's maddening. And the fact that even now, and I don't want to bash men, but you went and got re-educated because you're a woman going through this, treating women. Yeah. But this is what is, I think, stopping men from going back and getting educated to really be of service to their female patients. Yeah. Because they're not experiencing it. It's not something. But for those men who are on here, and this is no down talk to men, you are going to be experiencing menopause. If you've got a wife, if you've got a mother, a sister, a daughter, you are going to be experiencing this shit too. Just not directly. Yeah. So don't get off of here. This is something that's super important, I think, for all men to understand. There is a lot that goes on when a woman gets into midlife, and you're there to help, support during this time, because it's systemic through our whole body.
Yes.
Okay. How do we find somebody to help us? How do we find a provider?
It is a challenge. You and I both being in Merced, or having been from Merced, that it's a small town. So small towns have an advantage of word of mouth, and women can talk more easily with each other and spread that kind of information easier. And the power of social media allows us to share that kind of information much more widely. Yeah. So I think it's just really being persistent and going to as many resources as you can and talking to other women, because will be someone who can give some information that will lead the way into a provider's, office or care that will ultimately be at the benefit of that patient. But got to keep the conversation open because
ask your friends, you guys. If your friends are on hormone replacement therapy and they're in your town, they know where to get the hormones from. Ask your friends. That's like the first thing, right? Word of mouth. Ask your friends. There's also, I think you had talked about a National Association for Menopause Society that has a list of doctors.
Yes, they have a list of NAMS. It's NAMS. List, the directory. Now, I'm sure not everyone on the directory is, ideal. I have read and heard and seen comments of not everyone on that directory being, a full proponent of midlife care or menopause care. So I think it's just really important to talk to other women because sooner or later you're going to find someone who's getting good care, and hopefully that will lead women to a provider that they can work with. But telehealth is a very powerful tool these days, and I encourage women to think about if they don't find anybody locally to seek out care through a telehealth doc. It's not always ideal, but it's also a place to just get started. And
it also depends on depending on where you live. There was a comment that came through that said private doctors are so expensive, or private consultations are so expensive. But if you are willing to do a telehealth, I think Dr. Sogocio, your rate was like $380 an hour for a consult.
Yes.
But then all of the medications are all they're all paid for through insurance if you have insurance.
For me, I had shared with you that I chose to step out of the private insurance field of health because I felt very restricted, and I know firsthand how much time we need to spend with our patients. It's not minutes. It's not 15 minutes. It's not even a half an hour. I give each of my patients a full hour, and whether they need it or not, or they want it or not, I'm available for a full hour. And I will tell you, it's because there's so much about this topic, especially, but women need to share their stories. They need to be listened to, and we need to have just an open discussion, because the only way they're going to build trust with me is if we talk to one another. And you can't trust your provider if you're only in and out of the room for 10, 15 minutes.
Well, with the whole list of symptoms that we have, it would take an hour to have the patient understand, oh, this is hormonal decline. This is hormonal decline. Oh, you're depressed or anxiety. Look at your hormone. Like there's a lot going on here. And I want to stress this as well. Even though there may be a lot of telehealth people that don't use insurance, and your medications, if you have insurance, would be covered. But if you think about that as an hour-long consultation in the subject of hormone replacement therapy that affects everything, by the time you went to a psychologist to talk about your mental health, by the time you got a DEXA scan about your bone density, by the time that you went to a nutritionist and decided, like, okay, what am I going to do about my spare tire here? All of this stuff, because the estrogen receptors are throughout the entire body, you're really kind of specializing, but also it's an all-encompassing kind of consultation that, without being properly diagnosed, you could spend a ton more time and money and all of that, and prescriptions, and that taxing on your health with all of that medication to try to address all these symptoms separately. If you're taking a sleeping pill and you're not on hormone replacement therapy, there's a problem, right?
Essentially, yes, correct. And I think it just, we have to understand that our healthcare system is very, very broken. And that is for both patients and doctors. We're on the same side of the fence for that. Stepping out of the insurance field really has given me a lot of flexibility, a lot of time with my patients, and no one should go to a provider that just says, okay, here's your refill, good luck, I'll see you in 3 months. You have to have a thoughtful conversation. Every time there's a follow-up or just a new patient consult or someone who's just transferring care, you have to take the time to go through all of those things. And especially medication surveillance and management, that's not a 10-minute conversation.
Also, too, just to piggyback on that, I have a lot of clients that go like, oh, I got my hormones, yay, I'm set. Your hormones still decline.
Change.
It's one of those medications, hormone replacement therapy is one of those types of treatments that for that first decade, really, you have to be on top of it, because as those symptoms start rearing their head again, if you're getting a hot flash, you're insufficient in the amount of estrogen that's in your body. If your inability to stay asleep is related to your hormonal decline, you don't have enough hormones. And that will continue to decline. And so to be an advocate for your own health and make sure that, if nothing else, as a midlife woman, a hormone specialist is who you are adamant that you are making sure you are on top of it, because it affects so many other things. That to me is worth the money. And Stephanie Lane at 50 said, the real question is, can you afford not to? Can you afford not to be on hormone replacement therapy? Can you afford not that consultation? It affects so many things that I just got goosebumps. It affects so many things with women. And I'm passionate about it, because almost every single one of my midlife women that I coach one-on-one, it is the first thing I talk about, because it is so connected. And once they get those hormones right, they start sleeping better. Their depression and anxiety subsides. They lose a little bit of weight.
Yeah.
They start getting their mindset right, that midlife is not a death sentence, that it's an opportunity for so many things if we can just get our health right. And it starts in midlife with a hormone replacement therapist. That's my true belief in that, because it's changed my life so much. And any woman who's got all those hormones then stripped out of their body that they've had their whole life, to have those not in our system is such a profound change to our overall health, that is the question. How can you afford not to sit down with a hormone therapist and say, like, how is this going to improve my life? We know that it affects all of those big ones, the big diseases, the bones, the brain, the heart, the mood, all of that stuff. So, okay, moving on to our last question, because there's going to be a lot of people that are asking, okay, how do they get in touch with you first? And then I want to ask you, in all of your practice, what is your favorite form of estrogen, the delivery system of that? Pellets, patches, sublingual, creams, all of that stuff. But before, I know that a lot of people said, how do we get in touch with you? How do they get in touch with you, Dr. Sogocio?
Well, I will certainly share my contact. And I am in Merced, California, and I can be reached. You can certainly find us on Instagram. We have our Instagram handles that people can direct DM. But I will share my contact information. I'll put it on my own page and share it with you too, Darnell, so that people can call if they want to. But I am also available in California through telehealth, through all of California. And so, yes, it's important to me that people feel like they have access. I don't decide, how people should, spend out of their wallets, but I do agree that there is value in getting good care. And unfortunately, our current healthcare system doesn't allow us to prioritize that. So hopefully people will think that this is a good investment for them. Yeah, Merced, California. I'm the only Dr. Sogocio there, so it's easy to find me.
And I'll also, when I post this to my main feed, I'll make sure that I put up in the description, somebody put up here, thank you so much for that, Zernam, www.mochi, so MOCI, Merced.com. That's your website. Okay, before we get off of here, because this question keeps popping up, between pellets and patches and sublingual and all of that, what is your favorite type of, when somebody is just starting out on hormone replacement therapy, what do you normally put them on?
So for my new users, I will certainly recommend the estradiol patch, because it's very easy to manage. There's a lot more variability in the dosing and the frequency by which we can change those patches. So there's a lot of choice with that. Oral micronized progesterone is typically the route that I'll start with the progesterone. And for testosterone, I typically like to recommend new users with a cream, because like you showed earlier, you have that little pump, that canister. What's nice is that the patient herself can control how much she wants to give herself. And so that is at the control of the person. And, you know, testosterone sensitivity is different for all of us. So I like to give that control factor to the patient.
And that's then as they keep needing to adjust, when the hormones, your medication is like this, right? Your hormones start going down, you need to adjust the medication to get those hormones back up. So it is something that you need to really be on top of, right? And those routes that you suggested are easy to kind of scale up.
Absolutely. Absolutely.
Well, this has been like such a great show and so much information. Again, you guys, I'm going to post this to my main feed. And Dr. Sogocio, I'm going to have you back on, and we're going to talk about vaginal health next time and everything down south, because there's a lot to talk about with that as well. But I thank you so much for your time. Thank you guys, everybody, for being here. I'm going to post this to my main feed. I'll make sure that I tag you, and then I'll put your contact there.
Absolutely.
Thank you, Dr. Sogocio.
Thank you for having me. It was great.
Okay, happy Saturday, everybody. I will not be here tomorrow. I'm going to be spending the day at the pool with my friends, so I'm not going to be doing a live show tomorrow, but I will see you next Saturday. And next Saturday, we are talking everything healthy aging supplements.
Ooh,
those supplements that, like, what are like the foundational supplements that we need, and what are the supplements that we can take that will help us live longer in a healthier way, extending that health span right along with that lifespan. So I'll see you guys next Saturday at 12. Dr. Sogocio, thank you so much.
Thank you for having me.
Okay. Bye, everybody.